Well, good morning, everyone. Well, we certainly have missed seeing everyone, and we hope that you're enjoying your delightful summer. Welcome to Trio Maryland's August Zoom meeting. We are so happy that you could join us. I'm Marty Marin, and this is my wife, Michelle, and we manage Trio Maryland. We'd like to welcome all our members and guests this morning, and thank you for attending. Today's topic is navigating transplant-related diabetes, empowering patients through education and prevention. This is important information for all transplant recipients. For your information, there will not be a Zoom meeting in September, so have a great month. We'll see you in October. Now, Michelle will introduce our speaker.
Hi, good morning. Good to see everyone again. We are very fortunate today to have today's guest speaker, Dr. Nestoras Mathioudakis. His professional titles include Co-Medical Director of Johns Hopkins Medicine Diabetes Prevention and Education Program, Lead Diabetes Clinical Community, Armstrong Institute for Patient Safety and Quality, and Co-Director, Multidisciplinary Diabetes Foot Wound Clinic. He's also an associate professor of medicine. Dr. Mathioudakis, an endocrinologist and researcher with a strong focus on diabetes management and patient care. He has contributed significantly to diabetes research, authoring over 100 publications and participating in the development of consensus guidelines in the field. His studies have offered valuable insights into using health informatics for diabetes prevention and management. He's involved in several NIH-funded studies. Dr. Mathioudakis is researching the effectiveness of automated diabetes prevention programs and strategies to reduce racial disparities in diabetes technology access. We're very fortunate to have Dr. Mathioudakis address the Trio Maryland community today. Thank you so much for presenting to our group. Welcome, and I now turn the program over to you.
Thank you so much, Michelle, for that kind introduction, and it's really wonderful to be with you all today. Let me go ahead and share my screen here. I am going to be presenting today on something that I see often as a diabetes specialist, and that is transplant-related diabetes. Can you all see my screen and my slides? Okay. And so I'm really going to come at this today from the perspective of education and prevention, wearing my hat as the director of our diabetes prevention and education program. I'll spend the first 20 minutes or so talking about transplant-related diabetes, its background and its causes and how we treat it. And then the second half will really be focusing on our program and the value that, that these programs can have for patients who are navigating this transplant journey. And I'd like to start off with three patient cases from my clinic. These cases have been modified for patient privacy. I changed some of the details, including the gender and some of the ages and the dates. But what I want to emphasize with these three patients and have you pay attention to from the outset is how different their journeys are. They all three are going to get a liver transplant, but their path to diabetes is slightly different. And so for the first patient, he is a 69-year-old gentleman who was diagnosed with type 2 diabetes in 2005, just found on routine blood work. Managed initially with lifestyles or weight loss and diet, and actually for a year had very good glucose control. He then, his glucose reading started to creep up and was started on metformin, a common first-line medication for diabetes. And thereafter, Januvia, a second pill, was added. And then that was changed to Victoza, a daily injectable for diabetes, kind of like Ozempic. And some of you may have been on that in the past. In 2012, he underwent a liver transplant from cirrhosis related to hepatitis C infection and was started on immunosuppressant medications, including prednisone and tacrolimus. And the prednisone was initially a pretty high dose. And in that setting, his blood glucose levels really just skyrocketed, and he was started on two forms of insulin, a long and short acting. And then over time, Ozempic, a weekly injectable that we've all seen and maybe many of you are taking, which is very helpful for weight management. He was put on that and was put on continuous glucose monitors, and more recently has been using the Libre 3 CGM. So over the last decade or so, his A1C levels have ranged between 7.4 and 7.7, and typically our goal is an A1C of less than 7%. However, this patient had anemia, as many patients with liver transplants and other forms of transplants have. His hemoglobin levels have always been below the lower limit of normal. And the reason that I mention this is that the A1C test that we get for diabetes is a hemoglobin A1C test. And so if someone's got low hemoglobin levels, the hemoglobin A1C may be falsely low and sometimes even falsely high. So that's just one caveat on the accuracy of this diagnostic test in people with transplants who may often have underlying anemia. And so one thing we often use in these situations where we're not sure about the A1C is the data from the continuous glucose monitor. And his data look really good. His average glucose is 151, and his time in range is 79%. And so our goal is 70% or more. So overall, things are looking good. He's had diabetes for a long time, so he has established complications of retinopathy and nerve damage in his feet. And he wants even tighter control. And so we're now in discussions about putting him on an Omnipod 5 automated insulin delivery system, a closed loop pump. All right, so this is case one, somebody with pre-existing diabetes whose diabetes sort of progressed when he had the liver transplant. Case two is a 48-year-old woman who had no pre-existing diabetes. She underwent a liver transplant from alcoholic cirrhosis in 2021. And immediately after the transplant, while in the hospital, her glucose levels went up and she met the criteria for diabetes. She was put on insulin. However, within 3 months after discharge from the hospital, the diabetes completely went away. She didn't need insulin. She didn't need any medications. And she was put on prednisone and tacrolimus, just like the previous patient. Now, in the interim, after her liver transplant, she had lost some weight while awaiting the liver transplant, but after she was feeling better, her appetite increased, and she gained 80 pounds over the course of a year, actually. It was a rapid weight gain, maybe partly related to the prednisone. And in that setting, about a year later, her pre-diabetic range A1C of 5.8 jumped up to 6.4, and the cutoff for diabetes is 6.5. So she's pushing diabetes, and she's at the high end of pre-diabetes. And she is initially started on metformin, and because of the weight gain, was put on Ozempic, which is very helpful for weight management, but unfortunately she had some gastrointestinal side effects, and we had to stop that. She also wore a continuous glucose monitor because she kind of wanted to learn a little bit more about how foods were affecting her. She was put on the Dexcom G7. She had an average glucose of 144, and her GMI, or glucose management indicator, from the CGM predicted an A1C level of 6.7, which is actually a little bit higher than her measured A1C. Again, the A1C sometimes doesn't completely map to the average glucose in people who have had transplants and may have anemia. Her time in range was really excellent at 88%, and she had complications of neuropathy, possibly related to something else. And more recently, while on just metformin, her A1C has been 6.2, which is in the pre-diabetes range, and things are pretty stable for her. So this is a case of a woman who had no diabetes, had a liver transplant, transiently had diabetes. It went away, she regained weight, and then had pre-diabetes, which she's managing with metformin. And then this third case is a 51-year-old gentleman who underwent a liver transplant in 2019 from hepatitis C and hepatocellular carcinoma, as well as alcoholic cirrhosis. Was doing well. No diabetes immediately after the transplant, but in 2021, 2 years later, he was admitted to the hospital suddenly with a big jump in his blood glucose. His A1C had jumped up to 9.3%. He was symptomatic. He was thirsty, urinating a lot, and he was started on insulin at that point. He was managed with tacrolimus. And, as we saw him after discharge from the hospital on insulin, our goal was to see if we could get him off of insulin. And so we worked to, incorporate lifestyle therapy for him, metformin, as well as the Ozempic. And he made some really dramatic changes in his diet and exercise, was able to come off of insulin, and has been managing his diabetes with metformin and Ozempic, and most recently had an A1C level that was 5.4, which is stone cold normal. So this is someone, again, with no prior diabetes, did well for 2 years, develops kind of rip-roaring diabetes requiring insulin. Then we were able to get him off of insulin, and he has well-controlled diabetes on non-insulin medications. So the reason that I share these 3 cases is they show you that the trajectory that someone can follow with a transplant-related diabetes can be quite variable. Some people might have diabetes first, that gets worse with transplant. Some people may have normal glucose that's just brought out by the transplant. And then some people can kind of be going between pre-diabetes and diabetes and back and forth, that this is a fluid state, that you're not in one fixed category. The one thing that I would like to highlight about all 3 of these cases, which I didn't share in their timelines, is that although their journeys were all different, all 3 of these patients received diabetes self-management training, or DSMT, from a certified diabetes care and education specialist. And each of them had different needs for their diabetes at the time that they were struggling, and that those visits were incredibly impactful to them in getting better control of their glucose. And so I'll talk a lot about that in the second half of my presentation. All right, so post-transplant diabetes is a very common complication following solid organ transplantation. And it's an important entity because we know that having diabetes can contribute significantly to negative outcomes after transplant. So increased infection risk, graft failure, and morbidity just related to diabetes, but also mortality, specifically in transplant patients. And over the last 5 to 10 years, there's been a plethora of evidence that has come out about management approaches for this type of diabetes. And in fact, this presentation is really timely because just this year, an international consensus report was published that updated the previous one from 2013. I'll highlight some of the key takeaways from that recent consensus report. So the relationship between diabetes and solid organ transplantation is bidirectional, and I think we've seen that with those 3 cases. In many instances, patients may have diabetes, long-standing diabetes, that has led to end organ damage, for example, kidney failure. And that's the reason why they're requiring the transplant in the first place, or heart disease leading to heart failure and needing the organ transplant. So pre-transplant diabetes in this case. And then, of course, many people have completely normal glucose levels. They have the organ transplant. The immunosuppressive regimen is really harmful in terms of glucose control, the hormonal systems there. And then after transplant, they develop the diabetes. Just a quick slide about the terminology here. This nomenclature has been evolving over time. This was really first described in the 1960s, and at that time, the term that was coined was steroid diabetes, because this was something they were seeing in kidney transplant patients. Later, the term was changed to new onset diabetes after transplantation, or NODAT. But this term was felt to be misleading because upwards of 10% of people who are diagnosed after the transplant may, in fact, have had unrecognized diabetes prior to the transplant. So using the term new onset was felt to be not entirely accurate. There was a term transplant-associated hyperglycemia, which really describes the fact that the glucose could be, transiently high in the pre-diabetic range and then might go back to normal. So we can't commit to a term of diabetes because we don't know if this is going to last. So that was used for some time. But ultimately in 2014, what was agreed upon by this international expert consensus was that we'll call this post-transplant diabetes, whether or not it was pre-existing. And, this can include patients who may have had undiagnosed pre-transplant diabetes. So how common is this? There is a significant variation in the published literature on rates of post-transplant diabetes by organ type. A lot of this has to do with the variations in the definitions that were used for post-transplant diabetes in the study or how long patients were followed for. But on average, for kidney transplant recipients, it's up to 25%. Similarly, for liver transplant recipients, heart transplant studies show upwards of 40%, and lung transplant 30 to 35%. What are some of the risk factors for post-transplant diabetes? Well, there's some we can control, and others that we don't have control over. And the ones that are not modifiable are age, ethnicity, and family history, our genetics. But potentially modifiable factors, as we've seen with some of these cases, is obesity, treatment of hepatitis C infection, and now there are medications to cure hepatitis C, and then CMV, cytomegalovirus infection, is a potentially modifiable factor. The other important modifiable factor, of course, is the immunosuppressive medications themselves. So corticosteroids, steroids, or prednisone are notoriously challenging for diabetes management, regardless of what they're being used for, whether it's a rheumatological condition or an allergy. Anyone who has diabetes who takes steroids is going to see their glucose levels transiently increase, and that's because steroids reduce our peripheral sensitivity to insulin, as our bodies don't respond as well to the insulin we produce, and therefore the liver starts to produce new glucose and raise glucose levels. The other immunosuppressants like tacrolimus and cyclosporin actually also impact how much insulin is produced by the pancreas, and sirolimus increases insulin resistance. And then within each of the different types of transplant, there's specific diagnoses for each of these end organs that confer some additional risk. So we know that people with end-stage kidney disease who are undergoing the transplant because of polycystic kidney disease have a higher risk of post-transplant diabetes. Lung disease patients who have that from cystic fibrosis are at higher risk. Liver disease from hepatitis C. And then anyone with underlying metabolic-associated fatty liver disease, which we used to call non-alcoholic fatty liver disease, or NAFL, is now called MAFL. That seems to be a risk factor as well. And then along those lines, another risk factor is for people undergoing liver transplant is if the donor liver has more fat content, that's associated with an increased risk of diabetes. So, why do we care about this? Well, why is there so much attention around post-transplant diabetes? Well, there are increased risks, as I mentioned earlier, cardiovascular disease being the most important, probably, as any patient with diabetes is at higher risk for this complication. We know that high glucose levels impair immune function and increase one's risk of infection and graft rejection. And numerous studies have shown that diabetes is an independent predictor of mortality. One thing that's not as clear is whether this type of diabetes has sort of a different trajectory in terms of risk of complications like eye, kidney, and nerve damage, or whether those complications influence outcomes in post-transplant diabetes differently than in other types of diabetes. And of course, diabetes often goes along with other metabolic complications, high blood pressure, high cholesterol, and kidney issues. So getting back to the immunosuppressive regimen, one of the key principles here is that it's really important to tailor the immunosuppressive regimen to the individual patient based on their factors. And this is a balancing act between preventing, graft rejection on the one hand and worsening diabetes control on the other hand. So, while it is tempting to say, we should just take everybody off of steroids to lower the risk of diabetes or get them to the lowest dose possible, that comes with the potential for an increased risk of rejection. And, finding the balance between the regimen of an immunosuppressive regimen that can minimize post-transplant diabetes without compromising graft survival is really important and needs to be individualized. So this slide is from that international consensus guideline. I'm sorry the font is a little bit small. I kind of broke up the figure and I'm going to walk this through as an animation. So this is what's recommended in screening for diabetes pre and post-transplant. And the first step is, while a person is on the waiting list, is to make sure that diabetes risk factors have been identified and that they undergo a pre-transplant oral glucose tolerance test. The oral glucose tolerance test, many of you may have done at some point, especially pregnant women would have done this always. It's drinking the 75 grams of glucose and then checking your glucose 2 hours later. This is recommended as the screening test over A1C because it is felt that A1C lacks diagnostic sensitivity and is susceptible to some false readings in patients with anemia. And you really want to know as early as possible whether somebody has this. And so an OGTT is the recommended screening test. And that puts patients into one of 3 categories. They'll either be normal, they'll have prediabetes, or they'll be in the diabetes category. And the next step is, after the transplant, we're monitoring blood glucose levels early, in the days to weeks afterwards. And we're, again, putting people into one of these categories. Is this high glucose going to remain high? Has the person met the criteria for post-transplant diabetes, or will this reverse? And so we do an early oral glucose tolerance test around weeks 10 to 13. And again, that test will put somebody in the normal, pre, or diabetes category. And then we do this again a year later, as things can change over time, as we saw with those cases. And importantly, post-transplant diabetes can potentially reverse when it's diagnosed early after the transplant, if the diagnosis is made only on the basis of the 2-hour post-glucose test from this oral glucose tolerance test, if the hemoglobin A1C level is relatively low, or if the patient has a relatively lower BMI or body mass index. So, we need to watch and follow here to figure out where somebody is really going to land after the transplant. And then, of course, once we know where things are when they're stable, then we follow sort of practice guidelines for each of those categories. Beginning with lifestyle modifications. So whether a person has impaired glucose tolerance or prediabetes or diabetes, the foundation of diabetes is lifestyle. Dietary interventions that emphasize vegetable intake, lean protein, healthy fats, nuts and seeds, based around the Mediterranean diet, for example, have been shown to be effective not only in diabetes, but also specifically in people with post-transplant diabetes. Physical activity is essential. Exercise programs have been shown to reduce the incidence of post-transplant diabetes and improve overall health. And these programs, both our diabetes prevention program and our self-management training program, provide a lot of support to patients around behavior, motivation, and adherence. And this is admittedly a very challenging thing to do, especially in a post-transplant period where you may not be feeling your best, right? It's hard enough to do when you feel great, and everyone struggles with this. So this is where these programs can really be helpful. Now, for somebody who's tried lifestyle and is not meeting glucose goals, of course, we're going to be turning to pharmacological management. And this is the consensus guidelines algorithm, and there's two branch points here. One is for the immediate post-operative management, and then the other is what we're going to be doing in the outpatient setting. So typically, post-operative high glucose values in the hospital are going to be managed with insulin, both short-acting insulin to cover food and long-acting or intermediate-acting insulin to cover your basal insulin needs, like what you need to keep your sugar steady when you're not eating. And those are being adjusted, and often patients are sent home on some kind of scale that is modified by an endocrinologist or primary care doctor. Another drug that has been tested in some studies specifically in transplant patients are DPP-4 inhibitors. These are oral medications like Januvia, Tradjenta. There's others. They are helpful in managing the post-meal spikes. But if somebody is, weeks later, still having high glucose levels and the immunosuppressive regimen seems to be at a stable point, then we're transitioning over to the outpatient management. And here we're personalizing the glucose lowering treatment based on a couple considerations. And I will say that this area is a little controversial. Which specific medication to use and its appropriateness in specific types of transplants, there's a lot of debate around this, including if you look at the up-to-date guidelines, which physicians use as a resource, and compare them to these consensus guidelines, you're going to see discrepancies in what is recommended. But the general recommendation is that metformin could be used as long as the patient's kidney function is appropriate. Some people will be hesitant to use metformin in kidney transplant patients out of this fear that there could be a rare side effect called lactic acidosis. There seem to be some studies saying that that is a very rare and unlikely event, and that metformin is safe, even in kidney transplants. But again, there's some controversy around this. SGLT2 inhibitors are what we call glucose diuretics. These are things like Jardiance and Invokana, and they have a lot of health benefits beyond glucose control. Some argue that they shouldn't be used in this situation. I personally think that they have a lot of benefits and would recommend using them. And then GLP-1 receptor agonists are the drugs like Ozempic and Trulicity and Mounjaro, these weekly medications. Again, some people feel that they shouldn't be used in transplant recipients, but I have used them in a lot of patients, and they seem to be safe and as effective as in patients with other forms of diabetes. Now, recently, over the last couple of years, there's been a kind of a paradigm shift in how we select diabetes medications for patients, because there are two drug classes that, in addition to just helping with blood sugar management, have effects on cardiovascular and kidney outcomes independent of the glucose lowering effects. And so for patients with chronic kidney disease and heart failure, we really favor using an SGLT2 inhibitor. And for people who are struggling with weight management or they have established heart disease, we're really pushing a GLP-1 receptor agonist because of the proven cardiovascular benefit of these drug classes. And the same principles would then apply for post-transplant diabetes. If at any point the glucose control becomes erratic and there's a lot of variability on these non-insulin regimens, our concern goes up about graft function and overall risk. And so we would then start insulin therapy with or without some of these other medications. So that's the kind of general paradigm we use for medications. And with that, I'm going to turn now in the next 15 minutes or so to discuss our diabetes prevention and education program that I've helped co-lead the last few years. And this is a link to our program at the bottom there. It's hopkinsmedicine.org, population health/DPET. So our diabetes prevention and education program covers two evidence-based programs. The first is the DPP, or the Diabetes Prevention Program. This is a program that requires recognition by the CDC based on demonstrated effectiveness. Like, we actually have to provide outcome results to the CDC showing that for people who go through the program, they achieve the desired goals of weight loss and A1C reduction. This is considered the standard of care for all patients with prediabetes. The other program within this, the DPEP, is the DSMT, which is our Diabetes Self-Management Training Clinical Service. And similarly, this program requires accreditation from the American Diabetes Association based on outcomes data that we have to provide on an annual basis. And it is the standard of care for all patients with diabetes. So just some background, historically, both of these programs had been offered sort of separately at Johns Hopkins Medicine for decades, but the utilization was quite low, and that was not something unique to Hopkins. I think that was a national trend. I'll show you some data on attendance in a second, but we actively expanded over the last couple of years through funding that we received from the state of Maryland, the Health Services Cost Review Commission. This funding was a partnership with Hopkins and the University of Maryland Medical System. And the goal was to significantly broaden the service availability of these two programs across the state of Maryland, and to demonstrate that we could get a lot more patients through these programs, patients who really could benefit from them. And we're pleased to share that we succeeded in both efforts. So I'll start with the DPP. Again, this is the standard of care for all patients with prediabetes. And why is this program so important, and why is this sort of paid by Medicare and considered evidence-based? Well, it comes from this landmark randomized controlled trial published in the early 2000s, which showed that an intensive lifestyle intervention that emphasized 7% weight loss and 150 minutes per week of moderate intensity exercise was significantly more effective, that's this green bar right here, than metformin, an actual pill for diabetes, and placebo at reducing the incidence of diabetes, that's the progression from prediabetes to diabetes, over a 4-year period. That's a 58% lower risk of developing diabetes from just lifestyle. And again, more effective than a pill. And this program was delivered by trained interventionists. You had weekly to monthly contact. They focus on goal setting, self-monitoring, and motivational interviewing. And as a result of the tremendous benefit that this trial showed, the Center for Disease Control established the National Diabetes Prevention Program that now recognizes thousands of programs throughout the country. So the DPP offers significant benefits, first and foremost being it lowers your risk of diabetes, helps with weight loss, healthy lifestyle behaviors, diet, nutrition, quality of life, blood pressure control, sleep, and in the long term for health systems is cost effective because it decreases downstream healthcare costs. So what is the program? What does the program entail, and who's eligible? So anyone with prediabetes and an overweight BMI is eligible to join. It's delivered by CDC certified diabetes prevention program coaches who follow an established curriculum. And it is delivered in a group format, both in person and via telemedicine. And I will say that one longstanding barrier to the DPP for patients has been getting to a weekly group class in person. And after COVID, we virtually transitioned all of the in-person to to virtual, and attendance went way up, and people found that the telemedicine was super convenient. And right now, that is the majority of these sessions. They're telemedicine, it's flexible, they're offered at different times of the day, and people just really like the camaraderie of checking in with the group virtually, and the convenience of that. These are the topics that are covered, as you might imagine. There's a lot on nutrition, physical activity, how to self-monitor, calorie balance, stress and triggers, healthy habits, diabetes, and cardiovascular disease. There are 31 sessions offered over a 12-month period for the DPP, and a typical class goes like this. So there's a 5-minute check-in where there's a brief discussion with the coach, and there's reporting of weight and physical activity. There's a 10-minute group check-in where everybody sort of shares progress. There's group feedback and consolidation. Then there's the core content for that session delivered over 40 minutes with significant group discussion around that. And the last 10 minutes are setting an action plan around SMART goals. And then there's some homework, not real homework, but things that people are asked to kind of think about between the sessions. And so our program is a really top performing program. It's run out of the Brancati Center for the Advancement of Community Care. We have really high retention rates, very high attendance rates in the 90s, and the average weight loss is 5.2%, which far exceeds the national average for DPPs. And that degree of weight loss, although the original DPP was aiming for 7%, 5% it has also demonstrated significant lower risk of diabetes progression. So we often encourage people to lose 5% as a starting goal. I just want to share some testimonials from the program. So this person said that the DPP was very helpful to me. I learned new strategies for healthy long-term behavioral changes. I've struggled with weight for most of my life. I found the weekly meetings were very important. The coursework was structured. There was a warm camaraderie from both the participants and the coaches. The coaches created a year-long non-judgmental place to work on changes in habits and returning to healthy practices. I progressed from 10-minute walks to joining the gym and swimming again. The bad cholesterol dropped, the good cholesterol increased, and most importantly, my A1C is normal again without medication. This person said, "I'd like to talk about how the DPP has changed my life. I was hesitant about joining, but I'm so glad that I did. First off, this program opened my eyes about so many things like portion control, calories, fat intake, servings, as well as eating healthy overall. I can truly say that I've made a lifestyle change forever, and this was the best decision I could have ever made. I've lost over 40 pounds and counting. Thank you for allowing me to be a part of such a wonderful program." And we've had similar testimonials from many of the patients that have gone through and have had demonstrated significant improvements in lifestyle and weight. All right, so in the next few minutes, I'm going to share with you a little bit about our diabetes self-management training, which is the portion of the program that I really lead. That's DSMT. Again, this is considered the standard of care for all patients with diabetes, and diabetes of any type, type 1, type 2, gestational, transplant, you name it. There is something in here for everybody. This program, again, eligibility, any type of diabetes. These are delivered by board-certified diabetes care and education specialists. They often have diverse credentials. They may be registered dietitians, nurses, psychologists, sometimes physicians or advanced practice providers. And the format here is, I would say, largely one-on-one, because the needs of each person are really slightly different, although there are group offerings for DSMT as well, covering kind of common concepts like technology and pump, or like diabetes 101. And it is a mix of in-person and telemedicine right now for DSMT. It's about 50-50. Very similar program elements to the DPP. However, here we're covering more specific information about diabetes, glucose monitoring, pattern recognition, hypoglycemia management, and how to prevent diabetes complications. So fortunately, with this grant funding, we expanded from one diabetes educator, which is shocking for all of Johns Hopkins medicine, to now like 12 all across the state, and Baltimore City, Baltimore County, Howard County, Montgomery County. And our educators are on the hospital campuses as well as in various locations throughout Johns Hopkins Community Physicians. So chances are, I mean, if you're in Maryland, there's an educator near you. And they're many board certified, as I mentioned, with you can see their credentials, a diverse group of nurses, dietitians, and even a pharmacist here. So what is the evidence for DSMT? When you look at upwards of 80 studies that have been published on this topic, the overall A1C lowering averages to about 0.7 to 1 percentage point, which may seem small, but actually that magnitude of A1C lowering is associated with a 30 to 40% lower risk of diabetes complications. It's been shown to reduce, improve blood pressure and cholesterol, just self-efficacy for patients, improving their medication adherence and decreased complications. It's actually been linked to decreased all-cause mortality and lower healthcare expenditures overall from less hospitalizations and ED visits. Despite all of that, really, there's tremendous benefits. This is the percentage of Medicare beneficiaries with diabetes nationally who have received DSMT. It's actually shocking how low this is. We're pleased to share that our number has gone way up from this baseline. And when you look at commercially insured patients with diabetes who've received this, it is not much better. It's 6.8%. So we need to do better here. The patients need this education and support, and for whatever reason, through lack of awareness, time, and competing priorities, they're just not getting the service that they need. Some of the things that a certified diabetes care and education specialist can really help with diabetes is teaching administration technique. I mean, these devices can be complicated. Each of them have slightly different ways of giving the injection. So patients need to be taught on the methods. Sometimes there are barriers around medication access or cost, and the educator can help think through resources to get medications at a more affordable price, inquiring about side effects, really trying to figure out if there are barriers to medication adherence. And our program, one really important thing that they can do is that they can help adjust the insulin regimen independently as long as the patient is in our practice and co-managed. So we can help to get patients to goal a lot faster because they can see an endocrinologist. In a couple of weeks, they can see an educator, a change can be made, then they can see us the next time. And there's a huge shortage of endocrinologists in this country, and there's no way that they can see all of our patients with diabetes. So our educators really contribute meaningfully to the workforce of diabetes providers. Another area that they are really an incredible resource for is in diabetes technologies, which have evolved rapidly over the last decade or so. Many of you have seen these or probably wearing these continuous glucose monitors. There's a lot to learn about these things. There's nuances for each of them, how to adjust the alarms, how to respond to the alarms, what to do if the connection fails. And so we don't have time in a 30-minute visit as endocrinologists to cover all of this stuff. Here's where an educator can really help. And then even more is for these automated insulin delivery systems. And I mentioned in case one that the patient is considering this device, which is an Omnipod 5, where essentially your smartphone is controlling insulin delivery through data coming from a continuous glucose monitor in a loop. And so these are pretty complicated technologies that require a substantial amount of training and support. This is the Tandem Control IQ. This is the iLet Bionic Pancreas and the Medtronic 780G pump. So with that funding to scale, our program in this 2021 year, this was a planning year for this. We started officially in November of 2021, and we have had an over 10-fold increase in diabetes self-management training. As a result of this expansion, we've completed upwards of 23,000 visits in the last 2 years. More than half of patients had more than one encounter, and about half have been virtual. And this is a slide that I'm really proud of. This is the impact of the DSMT program on A1C levels. So the average A1C of a patient coming in right before the DSMT visit was 8.5. And at the 6-month check, it was 7.5. So through just education and support, we're seeing an A1C reduction of 1 percentage point, which again has so many long-term meaningful health benefits. So 1% A1C reduction across all sites. So if you are interested in either of these programs and you think you're eligible, and especially if you're within the Johns Hopkins system, this is the sign up page here. You can actually click sign up directly on the site. For the DSMT, referral from a provider is required, but our referral coordinators can help track that down from a primary care provider and endocrinologist. And just for the DPP, all that's really needed is evidence that you have prediabetes. So with that, I will thank you very much for your attention, and I'd be happy to take any questions. And I'm sorry if there were any in the chat, but I could not see them as I was presenting here.
Thank you, Dr. Mathioudakis. I mean, I tell you, that was really a ton of information, and I didn't realize that Johns Hopkins was offering all of those, both of those programs. That's really good to know. I wonder how many of our attendees actually knew. And I kind of lost the chat feature down here at the bottom of my screen, but there was one question from early on asking, what was in your very first of the 3 case studies, what was the kidney function of patient number 1?
Yeah, let me go back to that case and try to see if I
So
can.
those programs are open really to all people. They're not just for transplant recipients.
Correct. Yeah. So these programs are available to anybody with prediabetes, anyone with diabetes of any type. I believe in the first case that patient actually had normal kidney function. I'm trying to recall why the metformin was stopped. I don't think it was off of a kidney contraindication. I think he had some intolerance to the metformin with diarrhea.
And we could open this up to some other questions.
Yes, personally, I have a kid that's third transplant and probably pre-diabetes, but I don't know. Can he do this program? He lives in Germany at the point. Can he just log in, and is there a way for him to get into it?
That's great. So he is doing something kind of like the DPP, or for his...
Not yet.
Not yet.
Nope. Hopefully he won't need it, but
yeah,
I need to learn about it.
Yeah. The other thing I didn't have time to talk about is that if for whatever reason the traditional DPP is not something you think you can commit to, because it is, admittedly like a substantial amount of time weekly for a year, there are online or digital DPPs like Noom and Omada and Weight Watchers. They actually have DPP accreditation, and some people may find that the digital format of it, an app, is really all they need. And so I encourage whatever will work for your lifestyle and your personal situation. I think the important thing is that you get the support at the pre-diabetes stage, if at all possible, especially pre-transplant, because we know that things will progress after transplant. And as we saw with some of those cases, it was yo-yoing between pre and diabetes.
Any other questions? I'm very surprised, Dr. Mathioudakis. I tell you, it's usually is a very, I don't know. Like I said, I think maybe you explained everything too well. They just don't have the questions.
Or maybe people have lived through this and they kind of and have experienced this personally, and which is quite possibly the case. Hopefully it wasn't too simple, too simplistic, the content.
No, I don't think so. I mean, I know we do know a lot of people in the transplant community that do have diabetes, but I don't hear some of those specifics. And, I think you need to be a Rhodes Scholar to remember all those medicines that you mentioned. The only way any of them were familiar to me is because That's who spends all the money to have commercials if you watch any
Yeah.
TV. So
Yeah.
I only knew some of those names because of commercials and the
Yeah,
people
especially on the Olympics. Yeah, I mean,
dancing away.
it seems like every other commercial on the Olympics is a diabetes medication.
Doctor, I think you answered the question, but I want to confirm. I'm on the active transplant list after almost 6 years at Hopkins. I am a diabetic, but my last A1C was 5.6. But I'm going to leave them here at night only. But if I heard you correctly, if and when I get the transplant, where they tell me I should get one this year, that could change. So it could get worse. Is that what I'm hearing? If I heard you correctly?
Yeah, that's correct. I mean, it's not always the case, but most often for someone who has had diabetes or is like right around pre-diabetes, immediately post-transplant, especially with the high-dose steroids, things will get worse. But that's not to say that it would necessarily be permanent, right? As we saw, some people will just be this transient worsening and then it goes back to right where you are currently. So as long as you're being followed, which you will be very closely after the transplant, they'll figure out what of those 3 lanes you end up in.
Thank you very much for all the information.
Oh, you're most welcome.
I just wanted to put this out there. So I lived with diabetes type 1 for over 45 years till I needed a kidney, and did the research and got a kidney and a pancreas transplant simultaneously, and luckily preemptively. So I did not have to do dialysis before I got mine.
Nice.
And was on the wait list for just under a year in order to get the 2 organs. But yeah, living with the diabetes was very tough. I'm so glad that I got the transplant for the pancreas. I actually think that I hope that the pancreas survives, but if it doesn't, I can still handle the issues. I want the kidney to last as long as it can.
Sure. Well, thank you for sharing that. And I didn't really talk about pancreas transplant because it's kind of a smaller subset, but
yeah,
that is specifically for patients like yourself with type 1 diabetes who want to be, essentially have insulin restored, right? And so, and that there's definitely data to say that doing it with the kidney at the same time increases is advantageous relative to them separately. So,
absolutely.
congrats to you.
Thank you.
Hey there. Oh, sorry. Hi, I was hoping to add to the conversation. I actually went through the one-on-one coaching about a year and a half ago. I developed type 2 diabetes 19 years post-transplant, so I was fine until then. But I've lost 60 pounds. I have, my A1C is right around 5.6. So it's been quite a wonderful experience to have, a resource to have. I just wanted, if anyone had any questions about that, I just wanted to give it a little extra thumbs up.
Oh, thank you so much for sharing that, and I'm so glad to hear that had that impact for you. And sounds like you're doing awesome with your A1C. That's really great. Congrats.
Thank you so much.
Can I ask a quick question? So with the Ozempic and things like that, they're saying they're using it as a weight loss drug. Do you find that it's just for weight loss, or do you find that it's controlling your sugars that makes the difference for the weight loss?
That is an excellent question. So these drugs are effective in both areas. Most often what we find is the people who have the most marked glucose lowering are the ones who are experiencing some weight loss. But even if you don't experience a significant amount of weight loss, the blood glucose levels improve. So and the spikes after meals become less pronounced. And we can't really always predict who it's going to happen to, like who's going to lose weight and who's not. But I've had people lose so much weight that, the A1C goes down so much, they're actually losing too much weight and we have to stop. It's gone the other way. But independent of the weight loss effect, there's glucose lowering. And the newest one on the block, Mounjaro, which is a GLP and a GIP dual hormone, that one is super potent, even at all of the doses, at both A1C lowering and weight loss. So they don't always have to go hand in hand.
Okay,
Thank you.
That's great. Thank you for all the additional comments and questions. Is that it? Last call?
Yeah, I just wanted to mention that my wife is on Monjuro, and it does helping her A1C. But what, like he had mentioned, unfortunately, people are using it for weight loss, and sometimes it's hard for her to get her script. And she went 2 months without it, and her A1C shot up 1 whole point because she didn't have it.
This has been the hardest aspect of my job for the last 2 years, is the lack of availability of these drugs for people who actually really need it, like are at very high risk of not having it. Every single week in my Epic in basket in my electronic portal, there's maybe 15 or 20 messages saying, "Doc, I can't get Ozempic at this pharmacy. They have this one. Can you switch it to this one?" And we'll switch it, then we'll switch it back. And
Wow.
it's been really disastrous. And our hope is that the manufacturers in the next year or two will fix the supply problem, and this will be done, we'll be past this, but it is a huge issue. I will say that some of these drugs are labeled specifically for an indication around weight. So like Ozempic, which is called Wegovy, when it's being taken not for diabetes, is for weight management. That's a separate issue, but there are people taking Ozempic and Trulicity and Mounjaro purely for weight, who don't have any problems and don't even meet the BMI cutoffs for these drugs, that have diminished the supply for people who need it. And I just hope we're past that in the next couple months.
Well, I mean, I understand why they're doing it for the weight loss, because it's a stress on your system. So if they're controlling their weight or getting their weight under control, it's definitely a way to protect their body from other issues down the road.
Oh, for sure. Yeah, the benefits are there. But when we have to ration medications to people in this country, the people that are at greatest immediate risk are the people who have already experienced diabetes and are now susceptible to the complications. But it's not an issue that anybody should even be having to face. There should be enough medications for all who need it. And hopefully that we're going to be there soon.
Can I ask one question, doctor? If you were someone that used one of these drugs just for weight loss, don't you really have to stay on it for life, some level of it for life, to maintain the weight loss?
Yeah, that's a good question. There've been a lot of studies on this. Generally, when you stop it, there will be some weight regain within 6 to 12 months. Not often all of the weight regain. And personally, I think even if this was something that was taken intermittently in life, let's say you lost some weight, you regained a little bit, you lost some weight, you regained. The area under the curve, so to speak, of your weight over your life is what really matters in terms of your pancreas, your beta cell function, and your diabetes risk. So I don't have an issue with, first of all, I don't think if you take it, you're going to have some sort of tolerance where if you stop it, you'll gain more. Then you may end up back at your current weight, but that period of time that you were at a lower weight for however long it was probably advantageous to you. But no, I would say I think it depends on the person, and it depends on their metabolic profile too, and their other issues. So you can't say one size fits all for that approach, but a lot of people who are struggling with weight management have comorbid problems, sleep apnea, joint aches, diabetes, high blood pressure, that will all improve with weight loss.
Well, thank you very much. We appreciate your time on a Saturday. We hope you have a great weekend. And
thank you, doctor. And I want to thank everyone for attending today. We love seeing your smiling faces. Don't forget to check out our events page on our website for advance notices for future meetings. Check out our website at www.triomaryland.org. And all of our past meetings are posted to our YouTube channels for your convenience. And the last thing I'm going to say is have a great weekend, stay cool, and enjoy it.
bye-bye.
Thank you, everybody.